A quick note before we start, you can find all links and resources discussed in the video description, and please use them to support us. Please also comment, share your opinions and ask any questions. Thank you and enjoy.
All right. Hey guys, I'm Abhishek and I represent the Council of English Division Students of Poland. And we have our three doctors here who will be talking about UK Foundation Program Series, ATSP, How to Manage Bleeps. You have the stage, guys.
Thank you so much, Abhishek. Hello, everyone. Welcome to the next webinar of this series that we've started over a few months ago, UK Foundation Program Series. I hope I recognize some names. So I think some people have joined the ones from before, but we'll also introduce ourselves just again in case that there's some new ones from you. Before, I guess, we formally get started, this is sort of a disclaimer that this webinar is going to be a little bit different from the other ones in that, yes, we have a lot of information to give you as usual and a lot of content, but we really want it to be interactive. So I think you can use the mic button, but I'm not sure. If you can't, and if you cannot unmute yourself, then just use the chat and be interactive and answer us, because we literally have slide by slide waiting for your answers and then moving on to the next one. This is just going to make the engagement easy and make you remember stuff, basically. This is based on our experience, understanding that that's how it works. So Abhishek, I'm not sure if they can use their mic.
No, they cannot use the mic, but they can type in the messages.
Okay, great. Yeah. So feel free to type in the chat, definitely. Even if one person answers, we've been successful today. So quickly doing introductions. I'm Disha. I was born in India and I've studied in Medical University of Warsaw and graduated last year with Shruti and Meera. Do you guys want to say hi?
My name is Shruti. I was born in India and I graduated in Medical University of Warsaw last year as well.
My name is Meera. I was born in Malaysia, and as the two girls have said, I've also graduated from Medical University of Warsaw.
So all three of us graduated last year and have been starting to work in the UK for the foundation program in August. So we're nearing the end of our F1, as scary as it sounds, but all of these sort of weeks of having worked in different jobs, we have had a few things to share in terms of clinical tips and just handling your basic role and responsibility that is basically the expectation of that whole F1 year, which many of you are going to start in August this year. So I think the biggest advice is, of course, not to panic. You always have resources and we'll teach you how to access those resources. So starting off with our interactivity, what does ATSP actually mean? Because none of us knew what it meant, and that we're not expecting anyone to know, but maybe someone's done an elective, maybe someone's familiar. We'll give you like a minute to try to guess what that means, or even just Google and then answer, and then we'll move on to the next one, just to test if there's actually someone who's trying to be interactive. My eyes are on the clock. Well, wait a minute. Okay, so yes, this context, it means asked to see patient. So that's what we use to document whenever you get a bleep and go to see a patient. And bleeps are these sort of pagers that you get that gives everyone PTSD at this point, but they're very loud and they go off like a sound, and then you have to click them. So you get numbers, calls from nurses or any other teams, or alerts or calls, and you can call them back and speak to them. So that's a bleep, which you hold if you're on call or in a night shift, and then ATSP, asked to see patient. So we have a feedback form at the end, so please fill it, because that's the only thing that we have showing proof that we've done this. And please give any suggestions of anything you think can be improved and anything you liked, because that's basically what we need to prove this webinar. So over to you, Shruti.
So we'll just quickly go through what A2E is. Does anybody know what A2E is? Because at least when we were studying, this wasn't something very common. It's not something we've used in Poland, but it's quite normal to use this in the UK. So does anyone know what A2E is and why we use it?
So our expectation is to even just give like a basic 1 word, 2 word, anything you think of what this means. And most people, whilst that you have a vague idea of what it actually means, the clinical importance of this acute and emergency. Okay, great. We have 2 to 3. Yeah, Shruti.
Okay, great. So you guys have sort of gotten the idea, which this is a systematic way of just assessing the patient, especially when you're asked to see a patient, an unwell patient. You go through the A to E protocol, so you make sure that you kind of cover all of the systems. So I can see some of you have already given out the answers of what A to E could stand for. So we'll just go with that. Can we go on to the next? Yeah. So A is airway, as some of you have already said. So this is the first thing you would assess when you're talking to a patient. So if a patient's able to respond to your questions, the airway is most likely patent. I wouldn't be worrying about the patient's airway if they're talking to me in full sentences and they're not in respiratory distress itself. You'd also want to, at this point, listen for any sounds, abnormal groaning sounds. If they have a foreign body impacted, obviously they wouldn't be able to talk, but you can hear some groaning sounds. That's when you would think of sort of airway support. Okay, I see more answers. Airway support and sort of escalation at this point. But airway is just to check if the patient's patent, if they're breathing, and if they're not breathing, we've all learned the maneuvers to open up the airway as well. Head up, chin tilt, that's the basic maneuver that you would do in any ALS protocol. But when you're just going to see a patient, you're just basically having a conversation that would cover your airway. Moving on to B, which is, like many of you have said, it's breathing. Again, when they're speaking to you, is there any respiratory distress? Are they using their accessory muscles? Can you see them in just any respiratory distress at all? At this point, you would want to put them on oxygen. If their SATs are dropping below 92%, put them on some oxygen. If they're not in the ITU, they're not being monitored, so put on some monitoring devices, put SATs, get your blood pressure machine on. So this is when you would start doing all of that. So when we go through A to E, we want to make sure that we treat as we go. So if you see that the patient is struggling with oxygen, you give them oxygen. You don't go on to C without treating A to B. This might sound a little bit basic and redundant, but when you are in a very emergency situation, this is something to keep in mind, that you need to treat them before you follow the protocol. The protocol is just for you to have it in the back of your mind. And this is just a basic idea of what you would do, but honestly, I would just go through the look, feel, and hear approach. See if the patient's okay, listen to their chest. If they're having any troubles breathing, wheezing, give them some nebulizers, give them some oxygen. And if you really feel like they could be deteriorating from the airway front, think of any adjuncts, eye gels that you might want to insert if just non-rebreather mask is just not helping.
And then C, as many of you have mentioned, is circulation. But before I open the next one, I think back to interaction. What would we look in circulation? When you go to see the patient, you've done A and B, like Shruti said, you've done all these sort of basic OBS, maybe done some initial management. What would you see in terms of OBS that would help you assess circulation? Capillary reflex, perfect. And what's the normal capillary reflex refill time in the normal patient? That is okay. Heart rate and blood pressure, yes, perfect. Those are less than 2 seconds, perfect. Those three are basically the most basic and relevant things that you need to see and treat. And usually I think this is, of course, one of the most common issues as well, that a lot of patients are either hypo or hypertensive, maybe they're tachycardic or bradycardic, and you address to that issue on that front. If there's a patient that's hypotensive, what is one thing that you can do as a first line of treatment? What is something that you can ask the nurses to do in terms of treatment, in terms of giving the patient, which might help bring their blood pressure up? Fluid, perfect. So you would give a fluid bolus. This is literally it in terms of basic management. I think there's not much other expected beyond like ticking the boxes and doing the basics when you're seeing them and when you're documenting as well. What's more is, of course, you would look at if there's any loss of volume in terms of bleeding, or just look at the urine output as well and see what the input and output is in terms of balancing that patient's fluid. So of course, if there's any major sort of hemorrhage and bleed, then you localize that source, try to control it, get some help. This is also the point that you should think of getting some bloods and then potentially a VBG as well, to just see the initial results that you can get. And the last thing to think about is access, be it IV or IO, which is rare. I haven't done it yet. Most patients you do somehow manage, either they've already had a cannula if they're in hospital, or you can cannulate them at that time, or you just go in central sort of areas. So if it is an arrest situation where you won't be alone, of course, you can just start thinking in terms of central areas. So femoral is a good place to start with for an ABG perhaps. But of course, this is for when you have surrounding people and help. This is also somewhere you can maybe start thinking about some drugs that you can give them in terms of controlling the things that you've assessed. So if they're extremely tachycardic, or if they're very bradycardic, let's just take an example of if the patient has a heart rate of 160 and potentially they're going into some condition, what can we give them? What type of rate could that patient have, or arrhythmia? What type of arrhythmia could this patient have, which could be a heart rate of 160, 70? And then what medication could we give them? This is just an example. So of course, AFib, exactly. This is a very common presentation, I think, which is encountered. You just get a patient an AFib, which can be secondary to a lot of issues. And then you can give them some DIG in terms of loading dose, digoxin, other medications as well. But anyway, that's always senior supported. You're never going to make these decisions alone. It's just examples of things that you should think about. And then more basic examinations in terms of investigations that you can ask the nurses to help you with. ECG, X-rays, of course, they're not going to be ASAP on hand, but portable is something that you can think of. Blood transfusion in terms of volume, if you know that that patient's losing a lot of blood, something to just think about at that time. And then just requesting more scans like ultrasound and CT. Moving on to D, Mira.
So now it's D. You guys have already mentioned that it's disability, but can you just tell me what disability includes? Like, what are the things that we're actually checking? Exactly. Okay, you guys are spot on. Like, all of the answers are just as it is. So main thing we first do is the GCS, so the glaucoma score, sorry. So you just do the eyes and you check the motor and you check the verbal response and you calculate, usually when the patient is already talking to you, and you can assess the A to C, they're most likely going to be in the 14 or 15 out of 15 stage, and so it's quite stable. Then you do glucose, because I think it's one of the things that we easily can miss when you're suddenly going to see an acutely unwell patient, and you think of all the 4H or 4T, all the random things, and you're like, yes, glucose. What about glucose? Because that can also lead to a drop in GCS, whether it's hypo or hyper. Quick question, how would you treat hypo or hyper when you're next to a patient?
So maybe hyper first, or just hypo, like any of you can choose whichever one you want to treat. I've never seen the hypo kit, to be honest, but I think the nurses have it. I think we are just expected to like suddenly just give them everything on their. But have you seen the hypo kit? The nurses have it because they're they're supposed to follow the protocol, but we as the clinicians have to think a step further.
Fair, yeah. So pretty much if it's hyper, you think of like insulin, or usually the patient's already on a sliding scale and insulin's prescribed, so you just give a stat dose of whatever that's there. For hypo kit is an interesting thing. And yeah, it really depends on how low. If it's very low, you think of you want to give glucogel, or if it's like also you want like a rapid, and if the patient is not able to tolerate oral, then you skip to like fluids. So it's usually like 250 ml of 10% dextrose in my hospital. What about you guys?
Yeah. We have we have the protocol that we follow. So of course there's, if it's in a severe emergency, the patient's unresponsive, IM glucagon, which is one suggestion, is on the last one where the patient is, almost going to arrest, which is when you give it so 500.
Yeah. And so after glucose, we've got the pupil reactivity. So it's really important to check if the pupils dilated, or if it's just pinpoint, because that's quite textbook definition of if it's pinpoint, then you're going to think, okay, does this patient have opioid overdose? Take a quick look at the drug chart. You never know. It could really just reverse if you just give them a dose of naloxone. I've seen patients who had a drop in GCS and we gave like 2 doses of naloxone and the patient's all happy and dandy after a while. That's there. And then you also have to be careful of patients who are like complicated cases, especially those who've got like pain team as well attached to them, because these patients usually have a lot of pain medications together and they're always given together. And sometimes it's just happens where patients can have overdose, so it's always good to keep in mind for that. Next thing is posture. Posture is a quite unique thing because immediately you will think, okay, if the patient is having like a tonic or clonic setting, you might think, okay, is this person having a seizure? Otherwise, you can check the reflexes, but that will usually come into the GCS itself. And what else? You can do toxicology examination, but that's going to be the last thing on your mind because you've got to investigate and order like bloods and all of that. So it's not really on the bedside part of things. But yeah, that's pretty much for D. Moving on to E, as you guys have mentioned already, it's exposure and everything else. So mainly here, it's about temperature. And if there's any changes on the skin, so you want to check first for temperature, you want to check, okay, if the patient is spiking temperature, you think, maybe sepsis, maybe infection, like can we rule it out? Things like that. And if it's low temperature, you can think of sepsis as well. So temperature is important. Check if the limbs are warm to touch. Check if the skin has any changes like rashes or any bleeding from a wound or injury. You never know because sometimes the patients are covered up and you can never see it unless you take it out. A lot of patients, you can always miss the PV bleeding or PR bleeding if you don't actually check sometimes. Then you can also do, usually what I would do for E is also include if the patient has bilateral or pitting edema in both the legs, because that can be a sign of fluid retention, then you carry on from there. But other than that, you can also include allergies into this because sometimes the patient can have like an anaphylactic shock or the patient is like edematous, like angioedema, and you can think, okay, yeah, let's give a dose of adrenaline and see how that goes.
Shruti?
So that's just a quick overview of what A to E is: airway, breathing, circulation, disability, and exposure. And they've given good scenarios. This is, of course, just scenarios that could happen, but ideally you just go through it systematically, treat as you go. Treat airway problems, treat breathing problems, because those are the ones that killed first. So put them on oxygen if they are struggling to breathe. If they're hypertensive, give them a fluid bolus. But always check if they have a cardiac history, they have renal failure, because you wouldn't want to bolus them too much. I generally just go slow, 250 mils over 20 minutes. That should do it. I would try and be really careful with fluid resuscitation. You don't want to aggressively fluid resuscitate anyone because you could push them into overload and that would go into arrest and something more catastrophic. Just a bare framework to follow, and when you document as well, it's always good to mention A, B, C, D, put all of your findings, because that's what your seniors will go off as well when you're giving them a handover, escalating. It's always good to have it systematically and then for you to point out what you found. If the patient's tachycardic, tachypneic, it would just be easier to have it all in one place. So this is a good framework to follow. But that being said, this is just a framework. Anything else would depend on the situation itself. So sort of adjust to the situation and the patient that you're seeing, but just a rough idea to have when you go see a patient and on the bedside, especially when you're on calls and you are just one person on call. This is a good framework to follow. This is generally, I think, what all of us follow. It's just the rule in the UK. This is a good A to E assessment. A good A to E assessment will solve most issues. So just stick to the basics, get this sorted, and then if you find issues, escalate.
And then also, if you guys have any questions about any of the specific things, by all means ask in the chat, and even about this one in general. What I wanted to add was, I think we already mentioned it with Mira, but you always have to sort of eventually have some red flags in your head. So if you do think that in disability, for example, in terms of past medical history, it could be a Parkinson's patient as well, and that's what could be causing their airway or breathing issue because of swallowing issues and aspiration or something. So it's always worth sort of like keeping all these basic major red flags. In A and B, you can think of like asthma/COPD history. So as Shruti said, you always treat as you go if you know that, because usually you will always have a basic handover from either nurses in the wards or paramedics in A&E. So you will know that, oh, this is like a known COPD patient or a Parkinson's patient, or a very basic past medical history you'll always have as soon as you go to do that A to E. So if in ABC you do know that they're known COPD, they're desaturating and having issues breathing or something, you can right away start them on nebs and try to give them some bronchodilators and everything to just help you get started whilst you also work on your assessment. So it's always important to remember some red flags and associations. But of course, you learn on the job. Like now, all of us are so much better because we've dealt with it for a few months. But that doesn't hurt to have reviewed them anyway before you start. So if there's any questions about A2E, by all means, ask us. And then now we're going to move on to a scenario. So it's going to be interactive again. We're going to give you like a bleep situation, try to give you information one by one. So just try to be proactive and then let's take it from there.
Can you both actually hear me?
I can now.
Okay, sorry. Like it's just been lagging for me for a bit. Anyways, as Disha's mentioned, so we're just going to play out a scenario. Shruti will help me, and she'll be the nurse for me, and she will call me. So I'll be the doctor here. So I'll start by saying, hello, you bleep the surgical F1.
Hi, I have a patient in ward F3 complaining of abdominal pain since the past hour. The new score is 3, pain of 3, and I've given paracetamol. That's not really relieve the pain. Can you please come review?
Sure. Before that, can you just let me know what was she admitted for and what is she scoring for?
So she was admitted for chest pain and she's had a inpatient angio done. She's scoring for heart rate and respirates and temperature.
Okay, that's fine. Whilst I'm on the way to the ward, can you please do an ECG and start bloods and even a VBG for her, please?
Yeah, I'll get that done for you.
Thank you. So basically, when the nurse starts bleeping us, we're usually on a different ward. So there are a lot of cases where I think all three of us have experienced where there will be like a 5-10 minute or even sometimes 20-minute gap because you're assessing another critical patient and you can give this job to two nurses. So usually that entails bloods, VBG, ECGs. You can even ask them to prep blood culture if you want. So just simple things like that, just to make it smoother for when you actually do arrive in the ward. But yeah, moving on. So let's say I've arrived in front of the patient and I start doing my quick A to E. So I'm going to keep just asking you guys. So for my A here, what do we think it is? EWS score is 3. And as it says here, the heart rate is scoring for what it's scoring for is the heart rate, temperature, and also blood pressure. But
I think their question was more like, what does EWS mean? Because we know we're not used to this before we came here. So EWS stands for early warning score. And there's
it's
a whole
scoring system. Yeah.
There's a whole if you just Google it, if you Google news or EWS even, you'll see the whole table. I can show it to you in a bit when we go over to like interactive online stuff. But basically you have all these parameters. Do you want to just go through them, Mira, again? Just tell them like what news it incorporates again.
For this patient or in general?
In general, so that we can introduce.
Usually in general, as the nurse gives it to you, you will see the heart rate, blood pressure, saturation, whether the patient is on or off oxygen. Then you also have the temperature. Then you also have the AVPU. So like most of the time the patient will be alert. So that's not going to give you a score. That's pretty much it. And then there is this like graph kind of a chart that's just computerized at this point. So you just insert your results and it will tally up the scores accordingly. But you can just Google it and take a look. You almost always never have to calculate it manually by yourself because it's always computerized. So it's.
I think it also depends on the trust. Most trusts have a computer system, I would say, and they would flag up when you have a higher news score. So news is just national early warning scoring. So it just goes by a bit of different names. Like for COPD, it goes by CRUISE. For pediatric patients, it would go like PEWS. So it's just a basic national scoring system that the entire of UK uses. It's standardized so that nurses know when to escalate. If they're using high, they would escalate to a doctor by protocol. But again, you should check into the basic parameters because they could be using really high and it could just be their heart rate. So that's always something that you need to ask the nurses, what are they musing on? So anything where the sats are dropping low, I would review. I would not ask for more questions there. But if it's just, say, hypertension, I would say give them a bolus first. Let's see how they react. So this is just a scoring system that we follow in the UK so that they know when to escalate appropriately for you as well as your colleagues.
Yeah, don't ever be too alarmed when you see someone's just constantly scoring a 3 or a 4, because they just can be on oxygen 2-3 liters, and that's already going to give you a new score of 3.
Yeah.
So moving on to the scenario. So let's say I'll do a quick A to E with this case. So A, she's intact. She's talking to me. She's telling me, oh, it's really painful. It's in the right upper quadrant. It's been consistent pain. It's slightly sharp. You know, it's radiating everywhere. Paracetamol's not helping. Fine. So A is good. B, I check her chest. Chest is clear. There's no signs of any imminent infection. Then her blood pressure here is 148/96, but I know she's hypertensive. She's got hypertension. I check her drug chart. Does she have any? Has she had irregular medications? Yes, she's had. Saturation is fine, 96. She's not on oxygen, so that's a good news. Respiratory rate is 18. And she's also got like bilateral chest expansion. That's something good to note. I always put that in. Then C, I check her CRT. It's less than 2, so I'm happy with that. Her heart rate is 96. It's still within the limits of, it's still okay for me. Anything above 120, I would think, okay, let's do something about it. D, because she's talking and everything else is going well, she's going to be 15 out of 15. Her glucose, I'm yet to check. She's diabetic, so let's assume 9, 10. And pupils are reactive, so I'm happy with that as well. Then comes E, pitting edema. There is slight, because she's, come in with heart condition, but there is slight pitting edema, nothing to worry. There's no progression, there's no wounds, there's no diabetic foot ulcers that I'm worried about that may cause infection, because as it says here, there's temperature of 38.2. So I really have to think, okay, is she on antibiotics? Is she on the sepsis score at this point? Then I'm quickly going to do an apto exam, just, palpate, percuss, check how painful it is. And then move on. I'll write everything down, as I just mentioned, into my notes. It's always important to write it down as you go, because it's clear and concise for everybody else to read, and then you also know you don't miss anything. Then you can kind of narrow it down. So in your head, whilst you're going through the A to E, you already can think of, okay, what are my differentials? Could it be, could it actually be pain secondary to some chest infection, or could it be gastritis? Could it be some gynecological issues? Could it be some intestinal flare? It could be many things. So with the plan investigations, so with the bloods, and I'd probably think of a scan if there isn't already a scan booked in for this patient. But otherwise, I'll just write down everything and then I'll escalate if needed.
So in this case, we were thinking of what do you guys think is most likely in this case from the differentials, and what would we send the patient for based on that differential? So this patient had
so just recap, right upper quadrant pain, temperature, history. I would look at the history as well if they've had.
Someone's going for pancreatitis. Great. It's always better to act severe than not. But I agree that we were thinking of sort of giving you a cholecystitis abdominal picture, because it's a acute surgical situation. What would we send the patient for in terms of scan? Sort of the obvious, but at this point, everyone. Someone also asked that question about, Mira, do you want to take that, the suspect gynecological or something? Do you want to take that question, or?
Yeah, let me just read it.
Yeah. And also, whilst you read it, everyone's saying ultrasound great, non radiation imaging great, but also the patient's a bit unwell. So, and ultrasound doesn't happen often out of hours. If you're bleeped at 9 p.m., the ultrasonographer has gone. What are you going to do? The patient's unwell. We have to do another scan urgently. What scan?
And just
Said
to answer
CT.
the gynecological question, I've almost never ordered a scan without discussing with a senior, even if it's an ultrasound, and especially if it's overnight or if it's like after working hours, you're never going to get that scan. It's very unlikely, unless it's X-ray of like a chest or like, portable ones. But I think it's always good to escalate because your reg should be aware of the patients that are scoring. And if there's any acutely unwell patients, they should be aware of them because it's just good to have them to know what's actually happening and for them to actually be there with it and to talk you and give you an idea of what other things that you might be missing in your plan of action.
And I think it's also important to know that it's, again, differing trust-based. So we're going to have a slide of that at the end, that we're giving our advice based on our personal experience. But even though I haven't had a surgical job, but of course, if there's a surgical issue with even a medical patient, the whole point is it really differs on what your expectation is from your responsibility. So you're supposed to have definitely someone that you can ask for advice and escalate to, a registrar at basic minimum, but sometimes even an SHO. So that's like either an F2 or an IMT or a senior house officer, core surgical trainee, someone who's in the middle. Sometimes if you don't have that, you of course have your reg. And it's always a good idea to just, like Mira said, let them know and ask. But for example, in my trust, we can be expected sometimes to just at least request that initial imaging and then try to find the reg to try to chase and get a plan from them as well, or approve your plan. But of course it differs trust to trust. And someone also said, are you not allowed to do ultrasound? Well, we don't get qualified from medical school. We're not technically qualified to do ultrasound. Yes, we've practiced fast, but like how efficient, that's not being qualified. And you don't have that setting and that qualification either on a ward-based setting, I think. In my trust, ultrasound is not available out of hours, so you would have to get an ICU or an emergency medicine doctor or someone who's qualified. But by that point, if that patient's so unwell that they need that emergency service, you would just send them to CT.
And just to sort of give you guys an idea, if in the case it's acute cholecystitis, there's no liver function derangement, you would go first line, at least in my trust, you do an ultrasound. And once it's confirmed ultrasonographically, you do an emergency cholecystectomy if the patient is unwell. But there's another situation where, let's say the liver function tests are deranged, the patient is jaundiced. What would you be thinking of? A complication of cholecystitis. Does anyone know?
So you said the patient was jaundiced, right?
Someone's given a very specific answer, but before that, what would you be thinking of? Yeah, you would be thinking of cholangitis. So the imaging would differ in that case. Would you still consider ultrasound as the first line imaging, or would you consider something else when it's cholangitis? There could be something blocking the bile duct. What would you think for imaging? So generally, if the patient has no previous history of gallstones or bile duct stones, you would do an MRCP to map out, see if there are stones that you can get through ERCP. So at least in my trust, it's MRCP first, and then you do ERCP. Again, it differs with trusts, and if the patient is a known gallstones, they've had a recent MRCP that showed a CBD stone, you would go for ERCP. And it again depends on the situation, but yeah, you guys have gotten it right.
But at that point, you would definitely have a senior involved, so
you would. Yeah, this would not be you dealing with it, but it's just when you do F2 job, you would have to make some of these decisions on your own. You would obviously still have a senior at all points, but it's always good to know that these are the things that happen, especially if it's your first surgical job. It's really good to know that why do we do an MRCP? Why do we do an ERCP? These words get thrown around every day. I hear about 10 ERCPs, 10 MRCPs happening. So it's always good to know why they're happening. So you have your rationale and you know how urgent things are, so you can action them urgently as well.
And then, Mira, you were finishing off with possibly escalating to a senior. So do you want to do that maybe? And then we can tell them why you've done that for the next slide.
Why I want to escalate to my senior?
No, I mean, do you want to give an example of how you would do that, and then we can tell them what tool you used to do that, or we can ask them?
Yeah, that's actually going to be talked about late, like in the next slide.
Because I'm thinking we can give them an example, right? So do you want to just use this one?
And just because gynecological was written here, in any lady who is in the reproductive age, please get a beta HCG. Do not send them for scans without making sure they're not pregnant. It happens sometimes. So get a beta HCG, ask them for their last menstrual or period, check if they might be pregnant, because you don't want to give them a CT scan without knowing for sure. It happens sometimes. It's a never event. It should never happen. So make sure you've gotten that sorted. Just because there's a gynecological condition that can happen, that it's been mentioned here, I just wanted to let you guys know that's it. You miss it sometimes, and it's really the basics that you shouldn't miss it. Normally in ED, they're very good. They get these done. But if there's a patient who's come onto the wards, not had a beta HCG, she's in the reproductive ages, be proactive, get it done. Your seniors will appreciate you for that.
Basically, the saying is that all females in the reproductive age are pregnant unless proven otherwise, and that's the way to go. Okay, we have a question. Would it be our job to notify the patient too fast based on the assessment? Do you always report back to a senior? So there's a whole spectrum of this in terms of an answer. We're going to speak about what do you do if you're very worried and if the patient's crashing. We're going to speak about that in a bit and give you an example of how you escalate that. But if the patient's somewhere where they're stable enough to go for a scan and you just are generally worried after your first assessment of, oh, they need some management, then of course you ask for some advice, because to request a specialist scan, you would ideally want to let your senior know that this is the plan. But if you're confident in your plan and if you have a rationale, then by all means begin initial treatment and then speak to your senior. So should we give an example about how to hand over to the senior?
Yeah, can you go to the next slide?
Are we doing, should we do it now and then ask? Yeah.
Fine. That makes sense.
Okay, so let's say I am escalating it to my surgical reg. So I'll say, hello, my name is Mira. I'm the surgical FY1 on call. There is a patient I would like your opinion on, please. She's a 45-year-old female admitted with chest pain due for inpatient angiogram. She's developed abdominal pain on the right upper quadrant with a pain scale of about 8 out of 10. She's got a background of diabetes, hyperlipidemia, history of gallstones, obesity, and hypertension. On examination, there was tenderness, guarding in the right upper quadrant with no signs of peritonism. In terms of her obs, she's tachycardic. She's also spiking her temperature. Her BP is slightly raised, but still within limits. She's not on oxygen. Sats are 96%. I've given her analgesia and I've taken bloods and ECG. They were all non-remarkable. Could you please review in regard to suspected cholecystitis, as well as any further action that you would like me to take? Thank you.
Dude, like if I have a doctor like Mira as a reg, I am like sorted. You don't have to do anything at this point. Imagine if you get such handovers. Anyway, what has Mira done now? Speaking to the registrar, we have something that's a specific tool, a format that you hand over that you should have gotten from the nurse as well, but there's a name for this system and tool that Mira used to hand over. And it's okay if no one knows, but at least maybe we can think about it. It's called Handover tool. If someone wants to cheat, and just Google and then type in the chat. We'll wait a bit. Oh, guys, we have an answer. Okay, Shruti, you can take over.
So this was S bar. This is what we use to hand over to your colleagues after your shift is done, or you're moving on to a different shift pattern, you're handing over to your seniors, escalating to your registrars. This is a framework that you would generally use. So S would be the situation, clarify who you are, what your role is, and why you're calling them. Make it very quick. This is a very quick summary of what the situation is so that they know how urgent it is. Background, give them a quick overview of what the patient is looking like, what the relevant clinical details are? They're really unwell. Do you want them to urgently come review the patient, or do they have a bit of time to review the patient? Assessment, what you've done, your A to E, what treatment you have initiated, what you've already gotten covered, given them fluids, given them analgesia, thought about some imaging, or started some septic screen if they've been spiking. And recommendations, this is when you ask the senior, what would you expect me to do at this point? Always clarify your expectations, as in ask your senior, is there something you would like me to do in the meanwhile? Is there something else I can add into this? Or if you're not competent with something, you're not comfortable doing something, explain this to them, because nobody is expecting you to do things that you're not comfortable doing. Of course, work within your competency and ask them, what would you want me to do? Is there something else I need to do? Am I missing something else? Do you want me to do something whilst I wait for you? These are all questions I ask my seniors, and most seniors are really helpful. They come, they review right away, but they expect you to start an initial management plan. So you need to have managed something. If they're in pain, please give them analgesia. I used to be really scared to give patients analgesia. I used to think they'd go into arrest, but I give morphine a lot now. In surgery, we give morphine a lot. Obviously, check contraindications. You're not just prescribing blindly, but please give them pain medications if they're in pain, because that could lead into an arrest. They'll start getting tachycardic really fast. They'll become unwell really fast with pain. If they're hypertensive, give them fluids. So do your basic management and use the SBAR tool to hand over or escalate to your seniors.
And then just a comment to my reply for the, is ultrasound more or CT more accessible than ultrasound? It depends on the condition, patient, time of the day. Every single factor determines what is more accessible and what's more useful, which is why you have a senior to discuss the plan with. So in this case, we had an abdominal pain issue and a surgical issue, and then possible, suspected surgical condition. So ideally, it would be nice to have it imaged sooner rather than later. But if it's in hours and, it's a Monday, like freaking 10 a.m., then ultrasound will possibly be more free and take them in the next hour as well. Similarly, if it's like a urological issue and if it's a sort of UTI kidney issue, then maybe it's not the best idea to get them down to CT anyway, unless the pre-contrast one is indicated like a urogram. And they can wait for the CT urinary tract the next day, ultrasound urinary tract for the next day anyway, because it's not that imperative and urgent. But anyway, you make these plans with a senior, and we'll talk about it a little bit more in common bleeps when we go down. So moving on to the next scenario. Is Mira my nurse now?
I can try.
Yeah. Be very annoying.
You'd have to start.
Oh my God, okay. I'm off nights now, so I just had a few set of night shifts, and this is basically what I was doing, all of them, when I was doing ward cover. So, hello, Disha F1 on nights answering the goddamn bleep.
Hello, doctor. I'm one of the nurses working in Ward 3A. I have a patient here who's having chest pain. Can you please come and review? I'm worried about him.
What are you worried about? What are the OBS? Can you do an ECG? What's their past medical history? And all of that stuff. And then
Okay. He's just saying that he's got a lot of chest pain, like he's having a bit of tightness, and then he's rubbing his chest, and he's saying he can't breathe. I will do the ECG, doctor, but can you please come and review him now? I don't know what to give him, and I don't know what to do now.
Okay.
And he's scoring
4 or 5.
He's scoring for heart rate, and his saturation is dropping. It's 95. It used to be 98. Should I put him on oxygen? What kind of analgesia should I give? They're all on the PRN section. Should I give all at once? I don't know what to do. Can you please come?
Very, very beautiful representation of what has happened in the past 3 nights. But yes, I also had a bleep for chest pain last night anyway, and that's what I kind of used to do this scenario. So I would ask the nurse who I'm still on the phone with that, yes, I'm on my way, but I'm reviewing a very sick patient on another ward, so I won't be there in the next minute. But whilst I come, can you please do an ECG? Newest OBS, if they're saturating less than 93, put them on an oxygen non-rebreather. Can you do some normal bloods with a troponin because there's chest pain, and bring out the notes with previous ECGs ready for me. And whilst you're doing normal bloods, can you also just do a VBG? And if they were febrile, maybe let's do cultures. And then I would hang up with the nurse, let them get started with this, because it's realistically going to take them a good 10 to 15 minutes to even set up the ECG machine, because it takes time. Every single thing takes time. Unless the patient's actively deteriorated and needs a crash call, you have enough time for them to do all of this whilst you make your way from one end of the hospital to another. And then I'll get to the ward. Also about pain relief, the nurse asked me what to give them. So this would be another question whilst you're on that call with them, that what do they have on the PRN side? Do they have any allergies? A lot of patients do have codeine allergy or something. And then possibly start with at least giving something. Paracetamol is always the best and safest option. You start with some basic analgesia and then go your way up. So I would ask them to give that at least, so that I can see if that's helped and affected anything whilst I get there or not. When I get there to the patient, I'm gonna do my basic A to E assessment that we've spoken about, whilst having some differentials in my head as well, because again, it's a chest pain, and maybe thinking of some past medical history, you're gonna have some risk factors in mind and start thinking about things. But in A to E assessment, airway is patent because patient's talking to me, so there's nothing obstructing, no foreign bodies. They do have an oxygen mask on because they were desaturating to 92, but now they're on 2 liters and saturating 99, so we can start even thinking about weaning that. Circulation, they were a bit hypotensive, I think, but very tachycardic. So that's something to think about in terms of management of what we're going to start doing. If they're hypotensive, I'll ask them to do a fluid bolus if needed. And then I'm already thinking about the ECG as well, because chest pain, you want to start thinking about seeing something on the ECG and help you rule out those things. What else? Disability, BMs will ask them to do whilst everything's getting ready. And then exposure, they might have been a low-grade temperature, so we're doing some cultures. What is our differential diagnosis at this point? What do we think, and what is our top priority of ruling out to make sure that there's something that we're not imperatively missing out that needs to be addressed to? Perfect. MI. MI is important to rule out to in a chest pain bleep, of course. And the way how would you do that? What do I need? We've mentioned that 10,000 times, but what do we look for in the ECG? Maybe that's more specific. Aortic dissection, yes, so it's in the differentials. Essentially, you want to think. I think of it in terms of groups. So even when I'm doing the A2E, I have some sort of groups sort of focused of what could be the potential causes. So whilst we wait for the TROPS and sometimes even the ECG, you're just thinking of these groups and trying to pin it down. Cardiac causes, MI, sometimes type 1, type 2, angina even, aortic stenosis sometimes, dissection, like we've said, pericarditis infections also sometimes cause it. And then you think sort of chesty, lung-related. So it could be a very new pneumonia as well, sometimes pneumothorax. PEs can also cause sometimes chest pain. Yes, like someone's mentioned. Perfect. GI causes. Okay, at this point, you guys can do the webinar. But well done. I think that's essentially the main red flags that you need to have in your mind, because a lot of times the patient just have reflux and that's not been treated, and then you go there in a rush, but of course it's relieved by an antacid. So that's something you should also think about giving in terms of treatment right away. You just give them an antacid and see if that helps whilst you wait for all these other investigations. We're running a little bit on time, so I'll move on. You can think of the past medical history and the cardiac risk factors. What type of risk factors would point us towards an MI differential being more likely? What kind of red flag risk factors would we think of? And then someone's answered about the ECG. So yeah, ST elevations, ST T-wave inversions, Q-wave changes pathologically, some bundle branch blocks we can think about. Perfect. We have some risk factors: smoking, obesity, diabetes. They can also be hypertensive, have had previous strokes, and just their sedentary lifestyle and those classic risk factors. It's also important to look at the previous ECGs, because if they're chronic changes, then you need to possibly change your management plan or not act so acutely and still get an advice, but it will still change your management sometimes because they can easily have like a bundle branch block from admission and be asymptomatic as well. And then you would just escalate to your senior that you have on hand, but also get started with speaking to cardiology or the nearest PCI center to get advice at least. They don't have to be transferred. And yep. And then in this specific case, the patient starts desaturating even more. They're on 4 liters of oxygen, but now they've gone to 75% and they're becoming short of breath and dyspneic. What do? You're very worried. You have to do something right now because you think the patient is going to lose conscious or is losing consciousness. No, we're not going to intubate on the ward. We're just F1s. We cannot intubate. We're not qualified. Good thought, but that's not. Call someone. Great. Who would we call? Yes, the lungs were clear. I auscultated, I think. Who would we call? Do I just be like, nurse, can you call someone? You tried though with the thought. Sorry, I didn't want to discourage you. Intubation is a good thought, but you've skipped all the 10 steps to get to intubation. Who do you have to get to? Cardiology consultant. Did someone say peri-arrest call? Yes. So there we go. Does anyone know how to put a peri-arrest call? This is expecting a lot because I didn't know this before I started working. So wonderful that all of you know so much. But how do you put out a peri-arrest call? This is a very long shot. Oh my God, great. You're doing amazing. Okay, Shruti, do you wanna?
So in general, you put out a 222 when you're concerned the patient would need airway support. Do you guys know who comes along in the team when you put out a 222? I can't actually see the chat, so you guys might have to read out.
I can help. We have someone has said no, that they don't know. We can just see if someone does know. But whilst we wait for that answer, if you're by the bedside with the patient and you're, literally worried that their heart is going to stop and you maybe have to start compressions, you have a whole bay of nurses, so you can literally just shout out and be like, "Hello, can someone help me put out a 2222?" That's all you have to say. Whoever is around, all they have to do is pick up the call and then dial 2222 and then say peri-arrest or arrest call, ward 9, bay 1, adult, that's it. And then who do we get? So someone's asked arrest team. So I think that's fair enough.
So when it comes to the arrest team, the bleep goes to the ITU reg. You get the medical registrar. And you also, I don't know if this is a common thing everywhere, but in the UK, you have highly experienced critical care nurses. So you have critical care outreach team. So you get a whole bunch of people, lots of hands on the deck, and you get lots of help, especially when it's a deteriorating patient who will likely need ITU admission, will need to be intubated. Again, we wouldn't intubate. The ITU reg, the anesthetist will intubate. So I've been on the other end. I've done an ITU rotation. So I've been to many 2222 calls. I've not done much, but I've seen what's happened. On the ward, it's a different thing. You would be the first point of contact. You might just have your nurses with you, and it can get scary putting out a 2222 call. But once you've put that out and you started the basic, that is, if the patient is arresting, start chest compressions, get more people to help you, get someone to bag the patient, start giving oxygen, all of these basic things that you need to cover before the ITU or the arrest team will arrive on site. Give them a quick SBAR handover, and then they'll get to work, help you with everything, access, airway support, and possibly then moving to ITU, which is when we generally put out the 2222 call. You can have a peri-arrest situation where you think the patient might arrest soon and you're just scared. You can put it out. There has been times when the patient was just in deep sleep and people have ended up putting 2222. Nobody gets angry for doing that, but obviously don't do that every time. But like, if you're scared, honestly, put it out. It's better to put a 2222 call. Nobody gets mad. I've seen the regis be completely okay coming on site, knowing that it was just a vasovagal syncope or it was just a self-terminating seizure. They're completely okay to come help you. So if you think the patient's going to arrest, put one out. It's always better to put one out. And in general, you might have different roles. If you're not the first point of contact, you might have to scribe, you might have to put access. It depends really what the role is, but just do the things that you're competent with and you're happy doing. Tell them if you're not happy, working a defib, tell them I'm not happy doing it. Just be completely vocal. It's okay to work within your limits, but it's not okay to if it wouldn't be right to not escalate. If you feel the patient is deteriorating, put one out. That's, I think, the basic thing we've all learned being in the UK, that it's okay to put one out. It's not okay to not put one out and something catastrophic happens to the patient.
I fully agree and want to emphasize it just again, because I feel like I undervalued the importance and understanding the responsibility for us as F1s who go to see that patient first. It's a peri-arrest and an arrest call that you have two options from, and there is no criteria for, I mean, arrest, of course, they're unresponsive, but for peri-arrest, there's no criteria. Even if you just think you need an extra set of hands because it's a night shift and you're alone, and the patient's really unwell, including just being sort of septic, and they're hypotensive and you need to do something, you need an extra set of hands, you put out a peri-arrest. Like Shruti said, it's better to put out one than not, because you don't want to be in a situation where they then arrest and you don't have hands and it was a little bit late. So your responsibility as the F1 lies in knowing that it's better to put out that peri-arrest. And then you get that extra set of hands and you get on. Okay, so I think we'll quickly go through this one and then try to sort of move on with the pace. But this was a general slide that we put together of common medical bleeps that you get. And I've gotten all of these bleeps over the past 3 nights. And generally the idea is that you want to be able to get as much information as you can from the nurse that is bleeping you about that patient. Because, for example, if there's that heart failure bleep that you're going to get, of course, the nurse is not going to be like, yeah, doctor, they're in heart failure. Can you come prescribe diuretics? No, it's going to be like, oh, they're a bit short of breath. Their oxygen requirement has gone a bit up. They were being treated for decompensated heart failure on admission. They're on furosemide 40, but now their oxygen requirement is going up. Can you come review them, please? And usually if they're desaturating, then you, of course, do the whole assessment, the A to E, try to understand what other causes there can be, because even a heart failure patient can get an infection. So you have to think carefully, do a whole management plan, but essentially offload them, ideally, look at the chest x-ray. So cardiac causes are usually common bleeps. Heart failure, dyspnea is often a common one. So in that you have to think of PE, examine their calves, do a D-dimer. Palpitations are another common one with arrhythmia. So sometimes they're very tachy, like we spoke about earlier, the AF. So you need to know some sort of basic drug management. Sometimes you can just give them some bisoprolol and they'll be fine as well. So you don't always have to give them ditch, like it's just an idea. And then sometimes they're very braddy, so you need to then be more sort of aware and careful in terms of what else you can give them. Fever is the most common medical bleep, I think, because patients can be already on some antibiotics and previous infection, but they can just become more unwell and worse. So while I speak about the next bleep, I want people to answer in the chat of what is the septic screen and what is the septic protocol. What is it called and what do you do in sepsis? So sepsis is another one, and then fall. Fall is another very common bleep, usually in elderly wards, but not more often than not in many wards as well. The most important thing is to not take it lightly, is what I've learned. Because, I mean, of course, initially, the thing that differentiates is, oh, was it just a little bit of a slip on the commode because they, got up too fast? But also, there's a very thin line of, yes, they could have easily fractured something because maybe they're old and stuff, but you always have to ask for injuries on the call, and then you decide on which pace you're going to run to that ward. Because if there was a head injury, you run, and then you get a CT head, do an assessment, and go from there. So last night I did have a bleep where there was a fall, and then that patient needed a CT head, reduced GCS, intracranial bleed. So it gets that serious. You need to be very aware of where you draw that line, but you have to ask for a right handover. This is why we taught you about that SBAR tool, not just for yourself to use, but also for you to be expecting people to give you that. Nurses always know this. So you have to just ask them for, what is the situation? What is the background? What do you think in terms of OBS, and are you worried? Can you do neuro OBS? And can you get these things done for me whilst I come? So basic neuro exam and then falls assessment. I think it's becoming national guidance to do CT heads in head injuries with fall patients, but I'm not sure in your trusts.
So in general, we if the patient doesn't know if they've hit their head or it's just unambiguous, and there's no drop in GCS, you would not consider a CT head because you're not worried of a acute intracranial bleed. But if they do drop their GCS at any point, you would need to do a CT head then. But in general, if there's a head injury, you do hourly GCS, then 2-hourly, 4-hourly, so you see if there's a drop, right?
Yeah. Yes, and then did someone answer about sepsis? I don't know if there is any. Do we have any answers about sepsis? No? Should we just move on? I think we can move on. And also, I just have to point it out, guys. The feedback form question is really annoying. So we're gonna give the feedback form after we finish the webinar, and then you fill it in, and then you get the certificates. So just wait. And then sepsis 6 protocol, yes. So this is the sepsis 6 most important basic management that is expected from you again. And you can always get help with this. So we're going to tell you about another team later that is always very hands-on-y, sometimes gets before you to the ward and starts all of this. But basically, very general. You give oxygen. You give 3 and take 3. You give oxygen. You give a fluid challenge. You can give them a bolus or just get them started on normal regular fluids, and then you give them antibiotics. Always start with broad spectrum, and then you can narrow it down. And then you take 3. You take cultures before you give antibiotics, blood and urine. If they have a line, then separate cultures from that line. If they have a wound, then swab it. You do a VBG and check their lactate, and then you measure their urine output, maybe do a culture as well, dip it. So if there's any questions about the sepsis, let us know whilst we move on to the next one.
We'll quickly go over the common surgical bleeps. Mira has already discussed in detail about abdominal pain, but just in general, A2E abdominal exam, check for any peritonitic signs. Does anyone know what we're looking for here? So I can't really see the chat, guys.
No one has said anything yet, but I think
we're just looking for guarding, rigidity. Again, you're sort of trying to rule out any acute abdomen, any urgent scan that might be needed, especially if it's overnight. It's really important to know whether the scan is justified. I would escalate, obviously, for urgent scans. I would be asking my surgical reg, hey, do you think we might need a scan overnight? Give them analgesics, cover the basic grounds. If they're in pain, give them morphine. We say start from paracetamol, but if they've already been on paracetamol, they've gotten a few doses of it, and it's not really helping, I would start them on morphine given they have no contraindications and they don't have any allergies to the medication. Another good option in surgery would be oxycodone. Again, it's trust dependent for us. We have an acute pain set, which we just order on the system. It does everything for us. It's quite easy. We're spoiled that way. And if the patient has a stoma, check the side of the stoma. Is there any infection? Personally, I'm not very comfortable managing anything related to the stoma, so I just escalate to stoma nurses if it's in hours. If it's out of hours and it's not an exact emergency, I would just see if there's any infection. Is there any reason that I would be concerned that the patient would get unwell over the next few hours before the day team comes in? Just try and basically stabilize them. On call, that's all you're expected to do. You're not expected to diagnose new things or anything, especially on ward cover. You would just be expected to manage the basics. Just let them be, keep them alive before the day team can come in and sort everything out. Another bleed that I've not encountered but I've seen happen is bleeding. If there's massive bleeding, you're not expected to manage that on your own. Please do not try and manage that on your own. You have to put out a 222 again. That would be the major hemorrhage protocol. And does anyone know when you activate the major hemorrhage protocol, what products you get without a form? That just keeps coming in. So in general, when you activate it, you get 4 O negative bloods, you get 4 FFPs and platelet. This comes in without a form, and it keeps coming in until you trigger stop. So if you're happy that you've sort of stopped the bleeding site and you've sort of given them enough blood and they're stabilized from that format, you would stop it. At this point, I would be sending out group and save. I would be monitoring HP levels post-transfusion. Generally, we do the repeat post-transfusion bloods 4 hours after the transfusion. Bleeding is not a very common one, but it can happen. I don't know if, Mira, you've managed any bleeding on the ward?
Yeah, because I was on neurology and TNO, bleeding was actually a very common thing you'd see post-op. And a very good way to measure it day to day would be, let's just say that a patient had a hip hemiarthroplasty. So on the side of the hip, they would have a long rectangular plaster or even like a square plaster. And what they do is you see the bleeding on day one and you just color, like you'd use a marker pen, you outline basically the bleed, and then you just check over the days if it's going more, if it's not. You cannot even bleed. It doesn't even have to be bleeding. Sometimes it can just be fluids just leaking out. Most times they just they might put in a drain to pull out all the fluids, or they might just leave it over the course of a few days and it might resolve by itself. With bleeding, there's nothing much. Usually you just check if the patient is on any VTE. So if they're on any anticoags, consider holding them because it's not going to make their case any better. Consider changing the dressings every now and then. Just keep an eye on the condition of the dressings. And that's about it.
And catheters, they're a big one. You get lots of bleed, both in medicine as well as I think in surgery as well. Now I'm on urology. If any of you guys have urology, it's a great specialty to learn about catheters. So in general, you don't want to escalate everything to the urologist. So we kind of have a basic idea of what you want to do when there's some issue with the catheter. So if the patient is in retention would be they have suprapubic pain, or the bladder scan shows more than 500 mils, catheterize them, relieve that pressure, because it's not going to help. It's just going to stay in retention if you do not catheterize the patient. And I think this is in every trust that male patients are not catheterized by nurses. So you do end up having to go catheterize the patient. If the patient has hematuria in the catheter, of course, or they're just having in general hematuria, you would want to still put a catheter in. We put a 3-way catheter in where there's 3 ports. So one for irrigation, where you continuously put fluids inside and push it out just to continuously have the bladder sort of irrigated so there's no clots. And then you do a bladder washout where you push about 50 mils of normal saline, pull out 50 mils, and just do that continuously so you can dislodge any clots that might be there. And most catheter issues with like bypassing or just not draining, I would say deflate the balloon, resite it, and then inflate it. You solve most of those issues by just doing that simple maneuver. If that doesn't work, recatheterize them. Also worthwhile to check, is it a long-term catheter? Do they really need a catheter? Have they been opening their bowels? Have they been moving? Can they just mobilize to the toilet? Are we simply putting a catheter in and just giving them another source of infection? Think of all of these things. Think of the patient holistically. Don't just treat the problem, treat things that can prevent it as well. And if it's a difficult catheterization, I don't know what the trust protocol for you guys are, but we give a gent prophylaxis post difficult catheterization. All of these things are important to keep in mind. And with catheterization itself, there's a lot of documentation, things that you need to be sure you do. Have a chaperone with you when you catheterize, males or females. Anything that you're doing, you do need a chaperone at most times. Document this clearly. If you're catheterizing, remember to keep the barcode or the serial number of the catheter so that you can document it. So all of these things you learn on the job. We don't want to like give you too many things that are trust specific that might confuse you, but in general, think of it stepwise. If there's hematuria, try and flush the catheter. That might help. And if you're still concerned, ask for your senior to come review and help you with that as well. Anything, Mira, you want to add about catheters or just surgical bleeps?
I think I want to add from a medic's perspective. So I haven't had a surgical job this year, but of course there can be overlapping issues in both the sides. So when we say surgical or medics, it means the type of specialty we're working in. So I've done medical specialty so far, but you can always get both issues in each. So for example, in a surgical patient, they can be septic, or they can just have some random medical issue that you would need potentially a specialist medical review for. Equally in medical patients and surgical issues, which is where you have to just think of red flags like we spoke about earlier. So like in my head, it's PR bleeding. You ask surgeons, gen surg, because most likely that's the cause and needs to be immediately addressed to. frank hematuria, fresh red new blood, usually would require a urologist input at some point because it's a new sort of red flag change. And then, of course, you initiate all these basic management plans, no matter what specialty, like Shruti said. And in my head, it's you really think of physiology. I think, again, having done a few months of working now, things make sense if you just think of physiology, because if you're seeing what's gone wrong and you try to source control that and treat it, it's almost going to be sort of managed. If there is sort of frank hematuria that's ongoing, there could be two things. It's either some sort of new pathology and something very horribly wrong, or it could even just be a traumatic catheter. So all you have to do is the washout. So you just sort of start with basic physiology and go treat that. If you're losing blood, you give transfusion. If they're peritonitic, you start thinking of infectious sites. So it's sort of all that basic stuff, and you go from there. I think there was a question about the dressing. So you've already said that, Mira, that the nurses do, but it's also, again, physiology there, that when Mira mentioned about the marking of the bleeding and or just looking at it, the same thing in medicine when you have like cellulitis or new rashes or new possible sources, you would just mark them. It's as basic as that of physiology, that you literally draw on the patient and then you just monitor it every day. So it's technically, it's not going to be more complicated and any harder, especially from our expectation. All you have to do is think basic, do the most important things. And then also just coming back to like the two questions. Someone asked about how often do we rely on the Lucas for the CPR. I haven't seen one in the Peri-arrests now because we hadn't come to that. It didn't go that long. Not sure about you guys.
I've seen it happen once in the it happened in ITU. We'd finished about 18 cycles of CPR. People, well, at that point you would put the Lucas on, but the thing with Lucas is there is a bit of time that takes to set it up. So unless you're really sure it's going to help, we don't really use it. That's the only time in my 9 months that I've actually seen a Lucas being used, and I think it's mostly used in A&E ITU. It's generally not used on the wards that often, and it's not a very common thing, but it does happen when they're seniors and they know how to manage it with the Lucas. It happens, especially when it's a long CPR cycle.
And then someone also asked about the DNAR, which Mira, of course, answered, but I think I just wanted to add from my side that, of course, when there's an initial arrest and there possibly isn't a DNA CPR, but the patient's, of course, frail and has those indications, but there isn't a form, you do, of course, start with that, because if you have a normal treatment escalation plan, which is for full escalation, and you're doing CPR, start that. You'll have the specialist team by then, and then the decisions will be made. So you don't have to worry about that. You just look for the purple form or the DNA CPR form, or ask someone to look for it. But if you don't find it, it's okay. Like, you can just, people have put out peri-arrests and arrests for DNA CPR patients. Like, it's fine.
And I think you should as well. The only thing we're not doing is starting CPR, but we are treating them symptomatically. We're doing everything to reverse it. So having the ITU, everyone can come. They wouldn't really do anything, but they could help with airway support or anything like that. We just wouldn't start CPR. So definitely put out a 2222, even if they are DNA CPR. It's a little bit of a gray area. I always find it really hard to navigate DNA CPR patients, but it's, again, you need to realize that there's some things you can reverse and there are some things you just can't, but you just do your best to reverse the things that are reversible. So if the patient's having a hypoglycemic episode, give them glucose. So just the basic reversible, your 4 H's, 4 T's, that's what you're, again, managing even in a DNA CPR patient. You just wouldn't start CPR. You wouldn't go on and give them chest compressions.
And then just adding to all of the stuff we've said already, that you escalate as soon as you can. There is this team called Outreach, or Critical Care Outreach. Is it team? Their ITU team. And I think they're the stars of the hospital at that point, because even as clinicians, we're not fully resourced. We're always understaffed, and there's always sort of never enough and cannot do everything. But Outreach has a little bit of a better build. I think they're specialized nurses that come from ITU training and have very sort of specific skill sets that help with addressing emergencies like that. And that's pretty much it. Like, you would also call them for advice if you need it. They're always almost going to be there with that deteriorating patient before you and begin a management plan. And they're also in touch with ITU, so they know in terms of escalation if there is beds and spaces for treatment, and getting the ITU reg down and escalating from there. So they always have a bleep. The nurses always almost bleep outreach before they bleep you if they're worried. So you'll be fine. But you can also bleep outreach. Like, sometimes I have also, just to get advice and speak about ITU. Then yeah, Shruti, do you wanna?
Just a disclaimer that all hospitals have their own protocols, they have their own guidelines, so always check your local trust guidelines. They will show that to you during your induction or whenever you start your first job. This is just some of our experiences, some of the things that we found helpful to follow during our F1 year, and in no means are we saying we're experts in foundation year and that we're completely trained. We're still learning. There's lots of learning to go. So we just wanted to share a really raw version of what we've seen help us during the job itself. Again, you're responsible for everything you do. You need to act as a responsible individual, follow GMC guidelines, be sure that you're treating the patient safely and you're being a safe clinician. Before prescribing, look for contraindications, look for allergies, look for interactions. These are all things that will come back to you. Sometimes nurses just tell you, please prescribe this. I would always go back to the drug chart, go back to the history, always check before you prescribe anything, because your name is going to be on there, and if there's something that happens, it will come back to you. So be responsible for your own actions and be safe. And we don't want to scare you guys with all of these rules, but it's always helpful to know you're not alone. You have seniors, you have amazing seniors who you can escalate to. They'll help you and guide you through all of these. Every hospital, I think we've all had good experiences in our hospitals. I think in general, I think we've had good support as well. Even being an IMG, I've gotten lots of support from my hospital. So really just be safe and take care of your well-being as well. It's always important to look after yourself. Don't get burnt out. Don't get too invested that you're affecting your mental health. Take time out for yourself, and yeah, just have fun. You need to learn as well. Your job is important, but you need to learn on the job. We've learned so much through these 9 months of just rotating through different specialties. I think we've all been getting good experience so far. So good luck with all of your first jobs if you're starting this year.
And just coming back to the point of being responsible for your own actions, this whole webinar was designed to give you tips and tricks that we didn't have. So definitely hoping that you guys have some sort of better pedestal starting off than we did. But at the same time, you are a qualified medical professional. You've studied for quite a few years and you are getting an official certification, which means you're responsible for your own actions. You have your provisional registration number and license. You're going to do a prescribing exam. You're going to be the one literally assessing patients and prescribing things. So it's not like a completely supervised medical school situation. It's a very responsible setting where you are very much responsible for your own actions, which is why you have all these escalation settings in place where you can speak to the seniors, ask for advice, and just say that you're not comfortable doing something, shadow people in the beginning, and then go from there. So that ties in with that question where someone asked about, can you get sued and is there some sort of legal team available for F1s? It's very rare, I think, for that to happen because we're on a provisional license. So we're supposed to be supervised all the time, which is why we always ask our seniors for a plan and document that. But from our side, we also recommend joining Protection Society anyway, because your hospital legal team will have some sort of protection, but I think it's more for them. So you need to do something for yourself as well. I'm personally part of MDU. There's also MPS, I think, and then just a few more. You're going to be told about those in your induction, so don't worry about that. But ideally, my personal recommendation is join BMA and then join MDU. And then you're sort of sorted. But of course, that's not a license to do something wrong and illegally practiced by any means. You are, again, very responsible for your own actions. Be aware of what you're doing and make sure. What other questions do we have? whilst there's a few questions coming in, we just wanted to quickly show this. This was some guidance that came up on the GMC website recently. I don't think it's still on the UK Foundation Program website. I might be mistaken. I'm just going to pop in a few links here, which I got from there, and then people can just go on there if you're interested. So this is for the 2024-5 graduates, the ones that graduate next year that will start foundation next year. So not the ones that start this year, but the ones that are next year. The GMC, the General Medical Council, the one that gives you your license, initially provisional and then final, have posted this guidance. So most likely it is definitely sort of final for next year grads. So you guys will be doing eligibility this summer. Your eligibility guidance comes out in a few weeks in June, and then it begins in July with IELTS probably. But the June guidance will include guidance about this exam. So all we've seen is what you guys see from these links. There is a PDF about what the content is and what is in the exam. It's divided into two. There's like a clinical section, I think. And yeah, so I don't think we know much more than what you would based on reading these resources, but I think it was an important thing to just highlight to all of the ones that enter. I don't think you should be stressed about it particularly because sure, it's a new exam, but the only year that didn't do a different or formal exam was the one that's entering this year. But we did the SJT, and that's an ethical exam, which will tie in this one as well. And if you're studying for your medical final year exams, you're very much going to be competent for these ones as well. So I don't think you need to worry. And then these are some resources. Someone asked in the chat earlier about is there something that they can use to review? So I think we're in the best time right now where we have countless unlimited resources, be it online or on paper physical form. But realistically, even though I have the Oxford Foundation books, I haven't used them as much as the apps. So all of these apps are fantastic. MD Calc, BNF, Mind the Bleep is amazing. Geeky Medics is even greater. A lot of like specific guidelines and your trust hospital resources that you should use. And yeah, should we start addressing these questions? Where do we start? Where do we apply for GMC? So ideally, if you're starting to work this year, then you'll start sometime soon as you get your diploma. You need to get it verified by the EPIC organization and then submit it to GMC and you get a provisional license. But you don't need to get the number as soon as you start working because you'll be in induction period, sometimes shadowing. So don't worry if it overlaps. Anything else? Do you need a GMC registration to apply for visa? Did we need? No, I don't think we needed the GMC registration for visa because yeah, I don't think you need that. And then I'm not sure what you meant by if this applies to EU graduates or it doesn't. If you mean by asking about the MLA, then I think it does apply to EU graduates because it's basically an exam for everyone doing foundation, including UK students as well. So that's why it's sort of important to highlight this. The UK medical students will have it embedded in their curriculum like the prescribing exam is from next year onwards. So will EU entries. So don't worry, you're just going to get guidance in the month. So the intake from next year is going to require UK MLA. Yes, that's what it means. You start eligibility this summer. If you don't have your diploma yet, can you apply to EPIC with something else? I recommend making your EPIC account and getting yourself notarized because for that you don't need your diploma and it costs and takes a good amount of time. By the time that's done, you'll have your diploma and then you can start the process. But yeah, formally, we finished the webinar, I guess. Here are our contact details. You can reach us on a few platforms and just ask us any more questions. Definitely give us more feedback about anything that you liked about the format of this webinar and what you would like to see more. And then, of course, now please fill in the feedback with those answers. And then hopefully you should get the certificate. And yeah, thank you so much for attending. We're still going to be here for a few minutes to answer any questions that you guys have. But otherwise, yeah, thank you. Will we have another webinar for the prescription exam? What do you guys say to that?
We don't mind. I think ideal time would be June, July, August-ish, because the exam was September for us, I believe.
Yeah.
We could go through that.
I agree. I think it's very much feedback based, which is why we emphasize so much on these feedbacks. So if you write in that you would like a prescription webinar for that exam, that gives us proof that you actually want it, as opposed to us just coming up with the idea. And we did some teaching for the prescribing exam after we'd given it Shruti. So I think that was a successful one where it was helpful to do that setting. So of course we'll be happy to add it on to this. The next slot would be September for your entry. And I think this would also come as prelim advice, where don't take it too easy. Like, it is a little bit of a difficult exam, but don't stress about it until before you start. So as soon as you start foundation, just focus on the charts and getting used to prescriptions, and then we can do the webinar and give you some practical.
But if you have the time, go through BNF, go through NICE. That would be you being a really keen F1 doctor. That'd be a really good thing to do. Geeky Medics, I think they're all really good resources. That's what most of us used.
Because that's what med students do right now. Like, the final year med students that are on the wards with us are very much, doing that, and they're very much acting as F1s whilst prepping for being them, which is what you guys should do as well. But I think, does BNF work outside of UK? I'm not sure.
It does.
It does. Fine.
I was able to actually, yeah.
Fine, that's fine.
I was trying to be keen.
Good.
I think
Okay,
it does
I have
in some countries. Because when I'm like when I was in Malaysia or like around East Asia, some of the countries didn't work. So I think it depends.
I guess it depends, but there is so many resources for PSA that you don't need to worry. What are the chances of working with any of us or shadowing us?
Depends where you're
coming to our hospital.
Yeah,
definitely.
So I don't think we mentioned this webinar, but we've mentioned countless times before. I'm in next to the London Deanery in Oxford. Shruti, you're in?
I'm in West Suffolk Hospital, Bury, so near Cambridge, East of England Deanery.
Mira?
I'm in the LNR region in Northampton General Hospital.
So
Any of you guys are coming to the hospitals we're working at? Yeah.
We're quite scattered.
We'd be excited, definitely.
But we'd be happy to see some familiar faces. I feel like it's, of course, common to have IMGs in Poland and European graduates, but not as common. So if anyone's coming in, then definitely come say hi, and we'll be as much of help as we can. And then in terms of shadowing, you can actually apply to do electives to the hospital, and I highly recommend that. Because the earlier you have an experience of the NHS, the earlier you know if you want to do it or not. So it's better to have elective experience before deciding to move your whole life there.
And some hospitals have extended shadowing for IMGs as well. Completely recommend doing that. I did that. It helped massively, at least with the transition. But for me, it wasn't that great of a transition because I started with ITU. But if you're on, I guess, medicine or surgery, it would be really good to sort of shadow the F1 who's going to move into F2. I'd recommend that. Definitely take advantage. It's just a little more hours. Obviously, you don't have to stay all of the hours, but it gets I think it's helpful to know the system because some of at least 1 week, not all.
Yeah, but it's still a start. Someone asked about
I did around 3 weeks. Wasn't fully paid.
Someone asked if we have time to do a PG cert during F1. I say no. Just because we're IMGs who've come from outside and we need to get used to everything. So as soon as you come, you're getting used to the system, NHS, country. August goes in that. September, you're doing PSA, you're busy in that. And whilst you're working all the time with on-calls, nights, settling, it's a little bit time-consuming. You just don't have the time to come back in the evening sometimes. And then you have a whole portfolio to maintain, which we've talked about in other webinars, and we're happy to do more specific things since ARCP is coming up, actually. So personally, my experience is I don't think so, unless you're a crazy time management person who somehow miraculously does it. But I haven't heard of anyone do that. What do you guys think?
I actually have a few friends who are doing PG certs. However, they are UK graduates.
Yeah.
It's doable, but there's a lot of time management that's going to be needed. But you can ask for extensions. They've asked for them as well.
Yeah, exactly. I think the smarter idea would be if you're planning to stay in UK for training, then do it in F2. So look for the opportunity in F1 because you need some sort of like place to start with and get a contact or something. look for the area of interest in F1, apply for it so that you can start in F2 and then just take your time and do it. It's very possible then. Yeah, exactly. Any other questions? We're happy to stay for a few minutes more. Isle of Wight is beautiful though. Some of my friends have been and they love it, but of course it's very isolated. But you have ferries, so I think you will be fine. But that's F2 you say, so I think at least in F1, if you're somewhere centralized, it's up to you. And you can apply for F2 swap shop. So each deanery has their own sort of swap shop situation for the second year. If you want to change your rotations or your location within your deanery, you will have like a spreadsheet and an internal swap. So you can look for someone who wants your rotation or your location and then try to arrange a swap. So don't be disheartened.
It's also good to remember it's just 2 years. It goes by.
Someone asked about, is there any opportunities to do publications F1?
You can. Definitely, there's much more opportunities in the UK for research. It could get a little bit difficult to publish, but I would say start out by joining an audit, get that experience. That's really helpful, and then go about publishing later on. But yeah, there is opportunity, lots.
I agree. I think that UK is much sort of bigger and accessible in that way, and you are expected to do some sort of clip or audit anyway for your portfolio. So you should start from there whilst you're getting used to the system, making contacts and getting yourself familiarized. And then you go on from there and get opportunities. You can do a taster week in F1 even, and try to get into that department where you're interested in, try to ask and everything. So you should very much have the opportunity, but be proactive. No one's going to come and offer it to you because there's a lot of people sometimes interested.
And I would recommend doing audits in the department you're kind of, at least the specialty you're kind of interested in specializing in, that shows commitment rather than just doing multiple audits in multiple specialties. So if you're interested in surgery, do a surgical audit, set up a surgical teaching program that gives you lots of points during your CST. So yeah, just go about adjusting your portfolio according to what you want to specialize in, and find more opportunities in the specialty. Even if you don't have a rotation, you can still show that you're committed by seeking out opportunities. If you ask, you get. That's what I've learned in the UK. If you ask, you get.
Mira, do you want to take the work-life balance one?
I think honestly it's been great. I think I can speak for all three of us. I think it really depends on how you learn to work your way through the jobs. Obviously the first week is going to be tough. You're not going to be efficient. You're not even going to understand how everything works. But along the way, you understand how to make things easier for yourself and others. And that way you will have a pretty decent 9 to 5 or 8 to 4 job, and you won't be expected to stay late. And also because you're in the UK, I suppose traveling would be it's a good spot to travel if you're someone who likes to travel. So yeah, I'd say that work-life balance is pretty great as an FY1. The responsibilities are very clear. The roles I think are well suited as someone who's just recently graduated. So I think with just time and patience, we will all get through it pretty well.
I agree.
Time management and just what's important for you. Try not to bring work back home. Try not to stress out. I think we've all had that in our first few months. It was really difficult to leave work at work, but now I think we're much better at that. Take time out for yourself, and definitely put that out on your portfolio as well. They really like you having a life outside of work, so put that on your portfolio, like, just relaxing or whatever you do to unwind, because that in turn helps with you becoming a good, healthy clinician and delivering safe care. So definitely look after yourself.
I think my recommendation would be book your annual leave as soon as you can. So all of those who are starting now, you should have emailed about your annual leave requests. If you haven't, do it now. The usual rule is 6 weeks before, but you should even request it months in advance if you know you want to go then. And just literally book all of your leave that you have. Book your study days if you have them. If you're interested in any sort of conferences and courses, book them, go. You have a lot of sort of leave allowance in that perspective as well. So I think it's a very wholesome experience, which you don't get in many other places. but I think that also kind of gives you an idea of what type of specialty and lifestyle you want going forward. So I had a heme job in my second rotation, which was in medicine hematology, which was a 9 to 5 job. And I've been always telling everyone about it, where I really liked it because I had so much more time and no nights. So you do get a perspective of what you want to do going forward if you're going to want that lifestyle for the next almost 10 years.
And it's also worth, if you are having just on-call shifts, nights, a full rota, it's also worth asking your trust for normal working days if that's something that's a priority for you. So again, look after yourself. If you feel like you don't really want to do on-call rotations for all of your rotations, it's worth asking them. They're really helpful with things like that, especially if it's not something you think you would want to do. You want your weekends off, you want your nights off, then yeah, definitely it's possible.
Someone asked about MSRA. I don't know of anyone who's done it in F1 in my cohort. I'm sure there must have been, but I don't know. But most people do it in their F2 in January and then apply based on the results or get interviews based on those results. And I think that's very reasonable because F1, again, I think you have to be even eligible. So I don't think you can do it in your F1 because you need a full license, if anything. And they have specific times that they sit the exam. So ideally you would do it in your F2. And yeah, just take your time. Like right now, your goal is survive F1. Kind of correlating with that question about passing F1. The requirements are to pass your ARCP, which is a competency. What is it? What's the full form?
Annual review of competency.
Progression, I think.
Yeah.
So that's basically a review of your portfolio and just a few things that let you pass F1. The amount of days you've taken off in terms of strike and sick. If your portfolio's up to date, manageable, no concerns, and resolved. If you've passed the PSA, if you've done your rotation, then sort of very much basic things that you have to do as a checklist. But it's not that hard to accomplish if you're done doing it all in the whole year. And then you can just take your time to do everything else in F2 because it's not going to be that, like focused or hindering.
It's also worth noting that the ARCP comes sort of in the middle of your third rotation. So try and get everything done in your first and second rotation. That's when you can get most of the things out of the way. So I would really recommend doing that rather than keeping everything towards the end. Then you're just rushing to finish whatever portfolio requirements you have for ARCP. So it's always just be aware of the things that you need to do, but take rests and take breaks. As long as you've completed your ARCP and your portfolio requirements, you're going in the right direction. And as for MSRA, it is MSRA, right? Sorry. Yeah, just look at what specialties need MSRA. Some don't. Some you can just directly write the specialty exam as per the Royal College. So it's worth checking that out as well. But generally, yeah, like Disha said, it's better to do in your F2 rather than in your F1 because you would be sort of dealing with other things in F1, and F2 is where you would be best suited to give the exam.
And I think after F1, you would also have a little bit of a better idea because it's one thing to think of an aspiration specialty in med school, but it's another to actually work in it. So if you've worked in a little bit of medicine and you think you might actually want to go into medicine training, now they have IMT here. So for IMT, you don't need to do MRCP, but ideally that's the route you'll go. You won't do MSRA. So or for surgery, you do MRCS and then going forward. So like Shruti said, it's very specific. Just a last round of questions. I think we've gone quite over time, but it was quite successful, I would say. We've actually managed to get so many questions and interactions. I hope everyone enjoyed it. We tried our best to keep it sort of as realistic and based on our lives and the recent experience. We'll be looking forward to reading the feedback forms to see what you guys are interested in next. I guess realistically going forward in terms of upcoming events, maybe we can aim to do something for that prescription one, in fact, in August. But maybe before that, we can just see something if there is a need and shout in the feedback forms and see to come up with something. But yeah, any final questions or we're gonna start wrapping up? Okay, thank you so much, guys. I think we're good. Abhishek, and we can end now. And yeah, by all means, reach out to us as well if you have any more questions. We're always happy to try to help. Thank you very much. Have a nice day or evening.
Thank you.
Thank you.
Please tell us what you liked or disliked about the video and ask any questions in the comments. If this video is useful, please give it a like. All links discussed in the video can be found in the description, and please use those links and subscribe to the channel to support us so we can keep producing content. Thank you, and maybe watch another video.